Assalamu alaikum. Hello everyone. I hope you are doing well and preparing excellent, uh, preparing very well for your upcoming exam. Okay, so let us start cardiology. I hope today I can complete cardiology and respiratory system. And tomorrow we'll do the May 2023 and also metabolic is remaining. Okay, so this is our plan after tomorrow. If you require any kind of help, inshallah I will answer in the if you knock me through WhatsApp. Okay, and also in the group I will check if there is anything to comment. I will comment, inshallah. Okay. So, 15 months old baby who is always sleepy, chronic nasal obstruction, snoring, his mother awaking him easily, but after 1 hour he falls asleep. Again, on examination, his second heart sound is normally splitted on chest extra heart sound. Almost 57% of the thoracic shadow, BP 100/78, abdominal examination normal. Patient was not in heart failure. So it was a long scenario maybe. So anyhow, they explain it that it was not heart failure, but patient having obstructive, not obstructive. So snoring was there. So it is like long-term snoring. Okay. So in that cases, how it affects. This is one thing. And they said that on examination, second heart sound is normally stated. Okay. Chest X-ray is mainly thoracic. It was cardiomegaly. Features was chest X-ray was seems to be cardiomegaly. BP was normal. One thing's recall paper I see that they give many things, like many information, but with the recall solving, you should now understand that where you have to give emphasis. So when you see the child having, you see chronic nasal obstruction and it is snoring is there and it easily waken up. So sleep was disturbed. It indicate there is obstructive sleep apnea. So when there is obstructive sleep apnea, it can affect in the heart by like right ventricular hypertrophy could be there. Even patient can develop tricuspid regurgitation. Okay, so all the right sided will be affected. But patient is not heart failure, so we can take right ventricular hypertrophy here. So, but sometimes pulmonary, when patient having RVA, then second heart sound, a pulmonary component become more prominent, but it is not like always present. Okay, sometimes it is difficult to ascertain as well. So here it is right ventricular hypertrophy. Then short girls with audible murmur attending ordinary school but need some help, which is the associated murmur. So this is a very easy question. Like nowadays, you should know. So short girl, which is our main syndromic baby, this Turner syndrome, they could have problem with the school and murmur, associate murmur, it could be coarctation of aorta or bicuspid aortic valve. Okay, so here we get this both things. So just we discuss one questions that is, you see, this is the question for Maliha, Dr. Maliha and Dr. Jamin. Just look at the question. sleepy, nasal obstruction, snoring, mother awakening normally. So sleep was disturbed, second hearts are normal. So just if you can look at the screen, this is right ventricular hypertrophy. Okay, but it is looks like tough. Okay, so also right ventricular hypertrophy possible in the top. Yes. So they give X-ray. Cardiomegaly was shown. Okay, so it could be there. Okay, but if you just see that how could be the RVH and LVH X-ray, can you see this? It will not come. Okay. So these things you should remember. And then Turner syndrome cardiac association is bicuspid aortic valve or coarctation of aorta. Yeah. Okay. So many ECG papers actually. Okay. Many ECG papers. ECG we if it is beyond the class capacity. Okay. Again ECG discussion. So rather you give some time to the for ECG. If required, then again you can hear. I think most of you have this recording of ECG. If not, I can give. Okay. So again, heard the ECG if required. Otherwise, you can see more things. And actually, everything you have to see: prolonged QT, hypertrophic cardiomyopathy, LVA, WPWT syndrome, first degree heart block, complete heart block, how they are looks like in the ECG and how can we identify. So Dr. Rumana is here. She was saying that, yeah. So LVH, RVH related things are discussed there. Just remember that LVH, when you see the LVH and RVH, so how is the R wave and S wave? By this way, you have to identify, okay? So in that cases, but like here just you can identify by the scenario also that Dr. Salma already did these things. Collapse during running. That means it usually QT. Okay, long QT. So we have to look over this. So just one thing is in right ventricular hypertrophy, if we consider, then RSR pattern would be there. Okay. So the RSR pattern, sometimes right bundle branch block associated, right axis deviation could be there. So these things also you consider. Then some measurement is there. So RSR pattern, right axis deviation. Then you will see how is their V1 and V6 R and S wave. Okay. So V1 you will get R wave is prolonged and V6 you will get S wave is long. And also T wave is upward. Okay. In the V1, you will get T wave upward. So again, I think it is not the appropriate way to again discuss these things. It will not give you anything. Like it's not the things just you hear me and you will learn. Now you have to work on you. Okay. This is the time to work on you. Okay. So you just take these things and PDF is there. By this way, you have to prepare yourself for the ECG, okay? Further, I can help, no problem. But tomorrow, I said before, that tomorrow we will do the metabolic and the May 2023. And after then, I, I will help by messaging, inshallah. Okay, so through WhatsApp or sometimes in the group. Okay, if I get any questions new or anything new comes to know, then I will share with you, inshallah. Okay. Then 3 years old child has recurrent blue ear, will undergo surgical procedure, and during her checkup accidentally discovered small PDA. What is the best management? This question is very important. So it is 3 years. First of all, we always think that drug treatment is required for PDA because it is a neonatal. Okay, it's not for the adult. 3 years childhood age group. So at neonatal age group, what things you will take? Neonatal age group, you can take ibuprofen, you can take paracetamol. Okay, so first of all, fluid restriction, then we can take these drugs and we can see how it is. If it is not improved, then we have to go for closure, surgical closure. Patient is heart failure and repeated drug attempt is patient is not improved. In that cases, we have to do the surgical ligation and it is open heart surgery. Because if you go for transcatheter catheter occlusion, it's not possible at the neonatal age. Blood vessels are so narrow, how can you proceed? Okay, so what happened? Usually it is from the femoral vein, or nowadays they use hands also, okay, hand veins also to catheter occlusion, okay, or valve closure, any type. So these things could not be possible at the neonatal age. Okay, so be careful about the age. Okay, sometimes these things are recurrent, PDA is there, so drug treatment failed. That time surgical ligation required and it's open heart surgery way. Okay. So for the 3 years old child, we can easily take transcutaneous catheter occlusion. So if it is happened, it is not becoming improved. So PD is continuing. In that times, we have to take C. Okay. So if less than 34-week gestation, how we manage the PDA? Just these things, what I said, drug, okay, medicine, first fluid curtail, then medicine. So sometimes the situation is so bad, patient is in heart failure, and for the PDA only, it is very difficult to extubate the baby. Okay. But for the childhood date, we will take transcutaneous catheter occlusion. Okay. So patient recently diagnosed with single heart ventricle, long synovial with high lactate. What is the cause of his high lactate? So what could be the cause? Single heart, single ventricle. So it is high lactate with, we know that this kind of child would be high lactate, and high lactate also possible in sepsis. If renal failure. So many causes are there. But here what we will choose. Okay. So it is related with the D. D is the right answer. Yeah. Actually, commenting here only is very difficult, but I did several, like, due to hypoxemia it happened. We just understand these things, but nothing is. They don't write it by this way. When there is single ventricle, in that case, it's not always heart failure or tissue perfusion, anaerobic lactic acidosis is not always related. Rather than if you just study on this, you can understand that in that cases, in case pulmonary circulation more than the systemic circulation lead to anaerobic lactic acidosis. Okay. because it is single ventricle. Okay, they have less peripheral circulation. Patient goes to shock, and they have high lactate as well. This question, I think is a task question. They give it in the AKP also. You cannot do anything. Okay, they are the Lord. Then again, you see many ECG question. So this is a question, complete heart block, first degree, heart block, second degree, third degree. So again, we have to read it because we know that first of all, heart block, there will be bradycardia. Okay. And if you see that D is the right answer, D is the right answer. In case pulmonary circulation more than systemic circulation lead to anaerobic lactic acidosis. Heart failure, why I don't say heart, not A, because not always related with the, not always heart failure is related to them. Single heart ventricle. Although I am right here, A, but I think heart failure is not always, but heart failure is, when heart failure is there, then of course there would be decreased tissue perfusion and anaerobic lactic acidosis. So it is the mention that the single heart ventricle. So if you just search for single heart ventricle, then you will get that, yeah, single heart ventricle with the heart failure, then this is the cause. But when there is single heart ventricle, but why there is high lactate, okay, then it comes to lactic acidosis come due to shock, okay, because systemic circulation is very less. So actually, there is some confusion with the A and D. Okay, so it is not very much like surest thing. You see, I said that it is A, but now I am saying differently. So it is actually task question, but still we can, you can also go further that, but sure, if you go through this question, you will get that lactic acidosis due to decreased tissue perfusion, but they mentioned this congestive heart failure, then so this is the problem here. Okay. Okay. So then another question, ECG related. So when you get ECG related and there is heart block, first of all, you find out the patient having bradycardia or not. If there is bradycardia, certainly you will get the patient having like, it is another option, sinus rhythm, complete heart block. I think it should be another option. Sinus rhythm and complete heart block would not be same. Okay. So bradycardia would be there. So in that cases, if you see RR, how much RR in between the RR, how much? So you can get it is a, and also P followed by QRS. Lead to you will find. Okay, so it is not a complete scenario, but we can, or X-ray. So in that cases, you have to see more. It is a complete heart block ECG. Okay. Yeah, it is a complete heart block because PQRS, it is, you have to see that sinus rhythm or asinus rhythm. That means any extra QRS come or any extra P. So there is asynchronous things are there or not. Okay, I was saying that I will not discuss with the ECG again. I'm starting discussion. Sweating irritability, what does this show? 10 months old presented with sweating and irritability. Sweating and irritability. It's actually very infantile age. Okay, what does the ECG shows? When you get any child having these types of things, sweating, irritability, your differentials are two, SBT or WPW syndrome. When you get this, just you go for two differentials. Yeah, it is WPW syndrome. Sweating, irritability, 10 months old. Sweating is there. So it is in that case, they are not febrile. Okay, you see. In that cases, you have to find out by SVT and WPW. Sometimes SVT is related with the WPW. Okay. Narrow QR, SPR interval is very low and there is delta wave. Today, my daughter said that you will take 10 minutes class, not 10 minutes. So I said that, okay, so you will come from school within 10 minutes. So she said that if I come 10 minutes, how can I learn? Okay. So I cannot learn. So I said that so that I cannot take 10 minutes class because I have to learn. Now she convinced. So any child, if they got fever or anything, so some days they become cranky, you know, these things happen. But I think this counseling works good. Okay, that why we are working, why we leave them. We should explain it nicely. I can remember my elder son. That times I was resident, so she always creates some problem when I want to leave for night duty. And that times one day I said that I have to go there because many child are waiting for me and their parents were waiting for me. And if I go there, they will get relieved. They will out of pain. And he becomes so much convinced with this. After then, not any single day he disturbed me that no, can go to hospital. Just share with you that you can use these things with your kids also, because every child become irritated because if their mom is busy. Okay, you can. Yeah, this is a great question when my study will be completed. Okay, so our VC sir said when I was resident, and guess I started my pediatrics things. That times VC sir said that when you understand that nothing, you do not have to require any things to study. That means you died as a doctor. So better we not died as a doctor, better we study. But exam is not good, yeah. I agree. It's really difficult and it's give us nothing. It's give us nothing, only pain. It's not improve our capacity, I think. So, oh, Dr. Maliha. Yeah. So, like, I think everyone like to study. If I say that you start to career or academic side or trying to do something. So they like to study, but this exam is stressful, both for our kids and us, our family life. So may Allah pass us in one chance, everyone. That's my prayer for you and for me also, so that they do not have to give much. Uh, when your study partner stops study partner, yeah, we all are study partner. Okay, Dr. Shahnaz. So this is very important that actually we can just pray like this way, so that we can pass and give much time to our family. So we do not want any relief from dunya, or we do not get many luxury with this dunya, but we want to get relief of this type of pain, or we want to give quality time to our kids and everything. And also as well as we want to do something good, so that we are started study. Oh, may Allah relief of this. Okay, after AKP, you will take some rest. Okay, some days, of course, you should take some rest. It is your right. Okay, so other than, thank you everyone. Just we are taking some relief. Okay. So after then, develop wide complex tachycardia and nurse cannot detect his peripheral pulse management. Okay. So narrow complex tachycardia means it is SVT. SVT management is different, we know. And when it is wide complex tachycardia, its management is different. And then another thing is these nerves cannot detect his peripheral pulse management. They say it, but it is like when wide complex tachycardia, ventricular VT protocol is to give DC shock. Okay, there is nothing to be chest compression. So in that cases, DC shock, how we give synchronized or unsynchronized. First, we will try the synchronized DC shock. If it is not, then unsynchronized DC shock. With the ECG paper, we will take this step. Okay, with the ECG paper, how the ECG paper is, along with we will go. So you see, it is written in the guideline. Synchronized DC shock initially less likely to when you see synchronous shock are ineffective. So in that cases, we have to go for asynchronous decision. But here they just mentioned 4 joule per kg, but it could be 2 joule per kg, then 4 joule per kg. Like the neonatal guideline, it is for the neonatal, neonatal guideline, they give this. Okay. Also, pediatric guidelines saying 2 joule, then 4 joule. Okay. Then antenatal scan shows increased echogenicity in the heart. So everyone get these things. That's very good. Rhabdomyoma. Yeah. Tuberous sclerosis, rhabdomyoma. Usually rhabdomyoma. Not always, but usually rhabdomyoma. Yes, tuberous sclerosis. So rhabdomyoma, or if it is brain, anything they mention, then cortical tuber subependymal nodule. Okay, 8 years old girl, mixed ethnicity, low-grade fever, come with sudden loss of vision, had large spleen below costal margin. She has tender bumps on the fingers and deep pressure, swollen fingers, paronychia of the big toe, high SR. What to do? This is a repeat question, and other questions also, anytime repeated question. Okay. So this question come different time, different way. Just sometimes loss of vision is there, sometimes not there. Okay. So main things is there. What is their presentation with the finger and hand presentation is here. Okay. So there is splenomegaly and there is tender some lesion on the pulp of the fingers, and also finger is swollen. Okay. So it is, what is the diagnosis actually? Infective endocarditis, yes. Echo blood culture, Okay, these two things for infective endocarditis. So everyone get this. Okay, so we know that infective endocarditis, if they are, then some thrombi could be there. For that, thrombus could be sudden loss of vision, goes into the eyes. It could be, and splenomegaly just palpable could be there. And these things are mainly, we get oslar nodes, okay, that is tender, genuination on the pulp of the fingers we get, splinter hemorrhage also, okay, but it is different if they are not white. In that cases, it becomes blackish, okay. So white people maybe looks like it's pinkish or red, but blackish people's maybe looks like more black, so that they can say paronychia. The question presentation, you see paronychia of the big toe. Okay. So mainly oslar nodes is their genuination. These are the painful and painless. Okay, splinter hemorrhage also there. bleeding under the nail. Okay, 4 years old child, attacks of respiratory distress and tachypnea occurs when she ran. But he wants two options. So just try to remember for this question, if not ECG is not there, you have to make your diagnosis. Okay. Don't confused when patient runs and something happen. It is long QT. Okay, and also they say it short PR. Okay, prolonged QT. So it is long QT. Okay. ST elevation is not typical for long QT. No, we do not get. Even not short PR. Short PR is not goes in favor of short PR is not goes in favor of long QT. So long QT is related with this problem. When she runs, then sudden fainting attack. But here complaints also different, respiratory distress and tachypnea. Then ECG identification, long QT is not difficult. We know that shortcut way. Okay, QRST. So like QRS. So what we said that in between this, we have to make a line and we will, I cannot write it properly. Okay. So like QRS. So how the T is completed, it is the important things. T wave, it takes long time. Then in between this RR wave, if you make a line, then you see the T wave is not completed. So by this way, you can easily diagnose long QT is there or not. So it is ECG related. Okay, I think this question we discussed previously. Father died ischemic heart disease during school screening program of a normal 8 years old child discovered to have a high normal cholesterol, normal triglycerides, and upper normal glucose. What you will do next? What you do next? So when you anytime it is also although said that before 40 years any persons died due to heart disease, then we have to screening the other family persons. But here 8 years old child, normal cholesterol, normal triglyceride, what you do? So we have to check the LDL. Okay. So familial hypercholesterolemia could be high normal cholesterol. We have to check HDL. Triglyceride is there, but most important is LDL, and cholesterol. More important is LDL. Okay, familial hypercholesterolemia could be there. Okay, neonate presented with cyanosis, chest X-ray shows a small lung for age, cardiomegaly, pansystolic murmur, heart, maximum the apex of the heart. On examination, there is hepatomegaly. What could be the diagnosis? Okay, so what could be the diagnosis? Yes, so it is Epstein anomaly. Epstein anomalies will be very small lung for age. And it is a one type of cyanotic heart disease. Okay. But box-shaped heart is there. Okay, box-shaped heart. You see, box-shaped, small. So maybe X-ray was given. Okay. So 12 years old presented with attacks of falling off his chair at school 2 times, and one of them was followed by abnormal movement for 2 minutes. What's your action? Okay, so this question is given differently. Okay, differently in different paper. Everyone was very much confused with this question. But if you say ECG, that means you are thinking of syncopal attack. Okay, syncopal attack, if there, then followed by abnormal movement for 2 minutes. Is it usual? Anoxia. I say that like if they say that followed by abnormal movement, then stop here. Then I will think it is full scenario is related with the syncopal attack. But when they say that abnormal movement for 2 minutes, is it normal? Like there would be the syncopal attack, there would be some precipitating factors like sudden anger, temperature, excessive hot, environment. So some precipitating factor followed by loss of consciousness, and it is written by this way that it's a transient, very it's not total loss of consciousness. It is like loss of awareness. This kind of word is used, loss of awareness. Due to that times, if it is vasovagal attack, then there would be anoxia in the brain, and it can lead to convulsion, but it is not for 2 minutes. Which you can, if you can count 2 minutes, is very long time. Okay, so again you will read the question, because same type of question can come as a complex seizure and also syncopal attack. If it is complex seizure, then your diagnosis would be EEG. But when you think over syncopal attack, then you will say it is ECG. Okay. So here, if you can feel that they want to say that abnormal movement for long time, then you will think it would be EEG. But abnormal movement 2 minutes, I cannot convince with this syncopal attack. Okay, same question comes differently. If you can remember, there is one question in your part 1 exam, that complex fight with her father, stepfather come, fight with the father, and then sudden loss of consciousness, and it persists up to 10 minutes. Okay, full recovery takes written differently. Okay, so it is complex procedure or it is syncopal attack. So if you go for masterclass book syncopal attack, in that books it is written it is for syncopal attack. Why? They write it a patient regain consciousness, but full recovery takes 10 minutes. So consciousness and full recovery 10 minutes could be after a sudden attack of syncopal attack. You may take some minutes to full recovery. So that is different meaning, but convulsion is continuing, then we'll go for it is complex partial seizure. You see that convulsion more than 5 minutes, then it goes that you have to go for active intervention. Okay, but here abnormal movement for 2 minutes. So I will say that somehow it could be two things could be there. So you have to use your information that you have, okay, for the syncopal attack and for the complex partial seizure. Okay. So if you say which answer for this question, it has no answer to me. Like I will say one answer and you will go and write this answer. It is not like that. You will, when you give the question, you will see that what information they give. I give you this information that syncopal attack for having a precipitating factors, usually vasovagal attack if they are, and it could be behind the cause cardiogenic things are also could be there, you know. So syncopal attack is there, then your first line is if you think from the scenario ECG. Okay, but when the convulsion is prolonged time and it is sudden, it occurs, okay, without any precipitating factors and something it takes long time to be recovered, then you will go for not recovered, long time convulsion is persisting, then you will go for complex partial seizure. Okay. ECG of a 10-month-old infant present a 6 hours history of poor feeding, irritability and crying. When his mom was carrying him, she felt a rapid heartbeat. On examination, is crying and CRT2. ECG was done. So with this ECG, if just say, see this ECG, you can, I think, without like further, you just should comment on this. Yeah, very right, very right. SBT. SBT means QRS, no PUR. Okay, very narrow QRS complex. So it is SBT. So how we know SBT management, what could be. But here important things, it is patient is patient not in shock, okay. Patient is crying, CRT 2 seconds, so it is not any shock. In that cases, what can we go for management? So I spec for the infantile age group, it's work good and it is 10 months. So I spec. And also you say it is current guideline. So if shock, then we will go for adenosine and further, but vagal maneuvers in between the time if we can help by any way. Okay. If there is no shock, then vagal maneuvers as I spec. Okay. Is that it? But not ocular pressure anytime. Even in the neonatal guideline, they say same way. Okay, but others, you see, this presentation is good. Okay, teenager swimmer presented history of syncope, QT is 500. So if it is there, but ECG was done and showed frequent dorsity points. Can you remember how the dorsity point? Yes, their line, isoelectric line will not be simple. It is like, and QRS is twisting. Okay. Polymorphic, yeah, polymorphic. So in that cases, beta blocker we have can start and intracardiac defibrillator, but there is a role of Maxalf also. Polymorphic VT is the dorsity points. Female present with headache, photophobia, seizure, confusion, BP is very high, puffy eyelid, in case urea creatinine. So something here could be like a renal cause, as patient is puffy eyelid, urea creatinine high, but patient having very high blood pressure. Okay, it's like malignant hypertension, 230, 140. Headache is also there. Maybe atypical any GN is there, so glomerulonephritis or lupus, many things could be, but here our main task is what we will go. We'll go for IV drug. Okay, sodium nitroprusside is very good drug to reduce the blood pressure. Also, IV labetalol could be option. Okay, you can take IV labetalol as well. So systolic 2/6 musical murmur heard in lower left sternal best heard when patient is online. This is very easy question. This is very easy question. So it is innocent murmur, first one, only 2/6. Okay, then second one is apex of the heart radiate laterally, so it is MR, mitral incontinence. Then continuous murmur, infraclavicular area, which murmur? Infraclavicular area changes with position. Yes, venous hump. Yes, venous hump. So fever, tachypnea, tachycardia, enlarged liver, tender. It's another questions which come many times. Okay, many times. And same way the question is same way. So this is patient could have tachycardia, tachypnea, heart failure like features, as well as you will get this patient having hepatomegaly. Okay, and heart failure is there at 16 intercostal space. Okay, it's dilated cardiomyopathy. Yeah, same questions come how many times? Senior of a teenager girl taking caffeinated drinks, then becoming dizzy, loss of consciousness. Her mom said that she was a bit pale when she found her. So actually, if there is an option, teenager girl, if it is not teenager girl, like it is infantile age group, just they say dizzy, loss of, we will take SVT. But teenage girl, usually SBT not there, but could be. And also it is caffeinated drinks, then become dizzy, loss of consciousness, which can cause caffeine, which can cause these things. With which disease? Esophageal attack also could be, but very rarely. Okay. Usually you do not say coffee causing esophageal attack. So it is atrial fibrillation. This is questions also came several times. I see cardiology respiratory questions is not very new one. Okay, so here I found that yeah, caffeine can cause atrial fibrillation. Not for all. Okay, so newborn mask ventilation for 2 minutes after develop dyspnea tachypnea, systolic murmur is there. This question actually 3 days old. Okay, so it should be TGA when there is no murmur, patient is cyanotic. Okay, but here they mention systolic murmur is there. Usually TG is not associated with systolic murmur. So yes, TOF is usually TOF not present very early, like within 24 hours. But after then we can find it. TOF with the systolic murmur with cyanosis. Pulmonary stenosis is not the usual age. QT 490, what is the treatment? So you can, it's a easy question. Easy question for long QT. What is our management? Propanolol. Yeah. Then 6 months duration, emotional liability, clumsiness, slurred speech, pansystolic murmur radiating to the axilla, abnormal movement in fans. Okay, so it is very easy. Emotional liability, clumsiness, 12 years, and MR murmur is there. So why these types of movements? Sydenham scoria. Very easy. Just actually, it is cath related things. Okay. So you have to just revise. Okay, ECG and cath. Emergency CS for fetal tachycardia. What does the ECG show? It is required some ECG now. Without ECG, how can we see? Sawtooth appearance, actual utter. What does the ECG again? Right bundle branch plaque. Prader-Willi syndrome with obstructive sleep apnea to abnormalities. So same type question it is. Okay. Okay, same type of question. If it is obstructive sleep apnea, then what can you get on the ECG? Could be right axis, the RVH, right axis deviation, pulmonary could be possible. Okay, but initially, if we take both three is possible. So first right axis deviation and P pulmonary, then the RVH, but they ask only two. Okay, so early manifestation you have to take, then the RVH will come. Okay, tachycardia, tachypnea after viral infection, with fine basal crepitation, tender hepatomegaly. It's very easy question for us. Okay, so you see the basic difference between the SVT and myocarditis. Okay, the answer is viral myocarditis. Tachycardia, tachypnea, crepitation, post-viral illness. Okay. Small PDA discovered incidentally by echo management. Same question now. Yeah, catheter closure. And then pedal edema, gone unit with murmur and pedal edema. In which case pedal edema is there with the murmur. In the Turner syndrome can be, they can, yeah, Turner syndrome could have pedal edema after birth. Okay. And Coe murmur is there. Okay. 4.8 kg with pansystolic murmur over fourth intercostal CPAP 48 hours after birth. What is the cause of murmur? So it is 4.8 kg, maybe not preterm baby, but pansystolic murmur we know for VST. Lower left sternal border. Yeah. Patient has jaundice with X-ray picture of butterfly vertebra. So look over the butterfly. We discussed this butterfly vertebra in radiology class. Some pictures are there. Okay, peripheral pulmonary stenosis, Alagili syndrome. Okay. Patient lying down, chest pain, 24 hours is taken when patient is lying down. Oh, it is ECG related, butterfly vertebra related. Then wave neck and widely spaced nipple, so we can make our diagnosis when we see. Yeah, is it? Turner syndrome. Yes. Uh, so this question again, you see, 14 years with Palo developed 2 episodes of seizure, one with eyes rolling up and unresponsive for 30 minutes. I think, is it my exam? May? No. Okay, and unresponsive for 30 minutes. And after minutes, development 1 episode of seizure with extended leave. Before the episode, she was helping her brother who hurt himself in this hack. There was the history of uncle have seizure diagnosis. So every time was having some things, but I think it's written 30 minutes unresponsiveness. Why hypertrophic cardiomyopathy? There is 2 episodes of seizure, okay? And one is generalized tonic-clonic type, rolling up, unresponsive for 30 minutes. And after minutes, develops an episode with the extended leave. And it was also with Hart himself, and another one was precipitating factor. Okay. So reflex anoxic seizure is not with this age group, okay, 14 years old, but syncopal attack could be. But problem is unresponsive for 30 minutes. Why? I think some writing mistake would be. Okay. But I think mm, probably it is a vasovagal attack, but other diagnosis, generalized tonic-clonic convulsion also. Yes, 30 seconds should be, but I see repeatedly they are written in 30 minutes. Okay. 30 seconds is okay. But we can take as a vasovagal attack because precipitating factors is there. If it is like 30 seconds, okay, then it is vasovagal attack. And it is repeat. Pallor and sweating, history of attacks of pallor and sweating otherwise well. What is the diagnosis? So again, you have to see the question, but WPW could be SVT, WPW. Fall from chair. Yesterday, today he falls again from chair and become unresponsiveness, develop seizure, then and get back to himself after 2 minutes. So this is the question which we discussed. Okay, so it is a repeat question. Okay, so if they give us some like ECG or EEG something, then we can easily say. But here, like ECG is normal. Then, but here they just say that no precipitating factor, just fall. Okay, and get back to himself after 2 minutes. Very vague question. Vague question answer. EEG, ECG, both could be. Okay. It is a question. It's the same as sample paper question. Same. No word is different. Sore throat, then admitted. Hematuria is there. Facial swelling, headache. Glasgow Coma score was 11 only. Convulsion was there. Blood pressure very high. There is hematuria, proteinuria. So what is the cause of convulsion? What treatment to be given? I think everyone can do this. I'm very sure. Okay, yeah, it is, yes, systemic hypertension, so much high blood pressure. So it could be the convulsion. Okay, labetalol, yeah. Even labetalol we can say because option was labetalol, okay. Yeah, sodium nitroprusside is not the option. It is VSD related after feeding with congestive heart already on oral captopril and spironolactone because decreased weight below second central maximum bottle feeding but tired easily. Cardiomegaly, plethora, sodium, potassium, low. What is the best management? So remember, VSD management, very important is their nutritional management. Okay. So it is not possible that mom will give breastfeeding and child will thriving well. It's not possible. Okay. They can give breastfeeding top of high calorie, highly dense calorie formula have to given. Okay, decreased used high calorie formula milk. I was thinking like this way. Here, high calorie formula milk is not possible, but we get the childs are very ill health. These types of child, okay, who having large VSD and operation not possibles. They have very severe failure to thrive. So NG tube feeding is must. Okay, 5 days old with X-ray boot shape. So we can say how the boot shape heart of no problem. 4 limb blood pressure high in upper limb and low in left lower limb. High creatinine and what could be the diagnosis? So in which disease there is blood pressure difference? We know it is coarctation of aorta, but when the coarctation of aorta is there, then it can lead to increased creatinine as well because of less blood supply. It can affect kidney as also. Even claudication could be for the limb. They are suffering from this. Okay, coarctation of aorta not require immediate surgery. This is the coarctation of aorta is there, then symptomatic management in you will see how they are progress, so how it affects. So after then you can go for surgery. So BP difference is not with the renal artery stenosis. Intermittent cyanosis in the figure otherwise will improve when putting hand and limb in warm water, Raynaud's phenomena. They give the answer. So intermittent cyanosis in the fingers. Intermittent cyanosis if there, then Raynaud phenomena. So it could be first red, then bluish. Okay, so it improves with putting hand and limb in warm water. It is also important. So what could be your advice? Raynaud phenomena having any numbness could be pain, needles, feelings, and you have to say it, do not smoke, do not have too much caffeine. Okay, do not take too much caffeine, you have to say, because it can aggravate. Yeah, so this is your advice. GP, what will give? Will give nifedipine. So nifedipine is the treatment of choice. So fetal tachycardia, we'll see the ECG, chest X-ray related with this. So what would be? Cardiomegaly, we can say at least. For this X-ray, cardiomegaly is revealed. But tachypnea, tender hypochondrium, fever, vomiting, epics. So it is looks like cardiomyopathy scenario. Okay. Scenario is cardiomyopathy. Cardiomegaly X-ray. Um, so this is question: patient with suspected infective endocarditis, past history of fever for 1 month, now fever irritability in the echo. What is the diagnosis? One culture already done. So some cardiac involvement because irregularity in the echo. So what we do for infective endocarditis? We have to send culture and then start antibiotics. Yeah, two culture 30 minutes apart and start antibiotics. Science of master course book is written nicely. So pericarditis related also there. Long QT cardioversion. You see many questions. So I will again check everything. So, but it's also very, you see, complex partial seizure and syncopal attack related many questions. Running his mother when she come to visit him at school, but suddenly fell down and lost his consciousness. So he come to hospital, what is a, but what you are going to do? So loss of consciousness not going in favor of EEG anytime. So we are concerning that they are having any abnormal movements, so prolonged abnormal movements or up-rolling hand movements, stiffening of the hands. These could be a confusing question, but it's very obvious that it is syncopal attack or some cardiac cause could be there because it is happened during the running time. Okay, so it is ECG is the answer. It is undoubtedly ECG is the answer. Okay. So very clear cut scenario. So I think cath related question less, you see, but cath related question recently less come, but it was there. Girl fainting episode when she get up to drink, she saw a black color in front of her, cannot remember what happened. So it is ECG related, okay? So it is simple. Pneumopericardium, shadow around heart for management. I think after then most of the question is cath ECG, and we discussed. Okay. So I hope you will go through now ECG and cath. Otherwise, most of the question we discussed. Okay. Now just we have to read the ECG cath. Anything you want to say, anyone? Whole respiratory recall, I get only one question with the lung function test. Okay, that means audiometry. Audiometry. Most of the question is chest X-ray related. So X-ray also very important here. So first question is radiology related again. Patient having epigastric pain, vomiting, fever to paracetamol and ibuprofen. Not improved, ask about for chest X-ray findings. So that was related with the chest X-ray and we have to think that which problem is there. You will get many questions like this. Many questions. Okay. So most of the question is like this. You cannot comment by checking on only this scenario. You have to see the X-ray and you can comment. So you see, when right heart border obscured, then you will see right middle lobe, hemidiaphragm, right lower lobe, right paratracheal, right upper lobe, left heart border, lingular, left hemidiaphragm, left lower lobe. Okay, so this is the things, just you have to manage it by remembering this chart. Okay, so we'll get many questions like this. Now cefuroxime for 5 days, but his condition did not improve. What is the best next investigation? Any child, if it is pneumonia, but patient is not improved by the use of broad spectrum antibiotics, then you have to think over that they develop proliferation. Just remember this line. It should be in your head, or you can say it by yourself 5 times, 10 times. Many questions like this. Taking antibiotic not improve. Okay, pneumonia patient. So pleural effusion, how can we diagnose? Confirmatory test is ultrasound. Okay, so ultrasound is the here diagnosis. 8-year-old child developed profound hearing loss. Mother has concern that he has decreased vision, especially at night. Worst balance, what is the diagnosis? So here problem with the hearing and vision. Some syndrome would have both problem. Although we know that CMV could be retinitis and hearing loss, but rubella also, these types of congenital infection also. But here, 8 years onset and problem with the like gradually decreasing vision, and then congenital infection is different. Okay, so 8 years the this problem would not be apparent, so we will not take it CMV or something. We'll take Usher syndrome. Okay, it has both problem. It's also very well asked question. Patient has nasal blockage, snoring, history of previous eczema and family history of atopic condition. Took oral cetirizine, but no improvement. What to add? Yes, when nasal blockage is predominant, in that cases, you can give intranasal steroid. But remember, it is not the first line drug. But when it is the first line, we will take cetirizine, then intranasal antihistamine. But if there is nasal blockage predominant or there is some polyp is there, we will take intranasal steroid after the oral cetirizine. Okay, again, these pictures, if you see, then you can make your diagnosis without any history or examination findings. Okay, please try to remember these things. I can remember this is the X-ray, came every year, and without any explanation, I can make the diagnosis. Okay. Bird's beak appearance. Yeah, CLE, CLE. Congenital lobar emphysema. Compressed, they compressed the lungs. Okay. So this appearance. Cough, increasing breathlessness. So whatever the symptoms, but 9 years, do you think thymus possible? Yes, it is lymphoma. But why not TAPVR? Okay, why not TAPVR? Okay, so let us see that how it looks like TAPVR X-ray. That is different issue. TAPVR could be without cyanosis also. APVR with obstruction, without obstruction. When they present it with obstruction, it's a very early age, and that times they will present it cyanosis. When delayed presentation, that would be without any cyanosis, and it is like pulmonary stenosis type of features. Okay, and so figure of 8, we can remember they have figure of 8 type of. This is a very common things we say, figure of 8. Birds. Yeah, istimeter sign. Snowman appearance, many things. So check it. Then this X-ray, what happened here? The presentation said everything. Okay. But they said antibiotics given base nest action, decrease breath sound on the right side of the chest. And then high grade small bone, large bone drain insertion or something. So it is not like we will go for very um, large bone drain insertion. It's not pneumothorax or anything. I think the small bone drain insertion is enough. Ultrasonogram guided, of course, ultrasonogram guided. Although we did many things in our practice, but here it's ultrasound guided. Okay. Uh, for this answer is already given. Okay, so it is when heart border obscured middle lobe. Okay. Baby born develop respiratory difficulty, saturation reduce, X-ray, there was a stomach bubble in the left lower chest, oxygen saturation 85% become 87%. Where is the option? No option. But if they say these types of stomach bubble, respiratory difficulty after birth, and X-ray, there is stomach bubble in the left lower chest. So you can make our diagnosis very easily. It's CDH, yes, diaphragmatic hernia. Why stomach bubbles comes to the lower chest? Okay. Neonate tachypnea, tachycardia, motile pale, FiO2 100%, oxygen. But saturation even low, metabolic acidosis, normal heart sound, no murmur is there. So if second day cyanosis without murmur, we just go for TDM. Yes. Then thick meconium develop persistent grunting, breathlessness, given 100% oxygen saturation, remains 70% admitted to NICU, intubated, no improvement in saturation. PCO2 4 in case intercostal diameter of chest, decrease air into bilateral symmetrical and mean just we did it, I think, yesterday. Okay, we did it yesterday. Why you were thinking sepsis here? So it just we did it now. That when there is meconium aspiration, so something lungs having some problem, and they could have cyanotic. So cyanosis, if they are in that cases, we think that there is something cardiac or pulmonary. But when oxygen are given but saturation not improved, so some pulmonary cause could be there. Which pulmonary cause? Persistent pulmonary hypertension of the newborn. Okay, their PCO2 is 4, that means normal after intubation. Admit in ICU intubated with no improvement in saturation, PCO2 4, increase intercostal. So even after intubation not improved because lungs having some changes that is that is not new. Okay. Now where is the problem? Consideration. Okay. Can we let's say it, but why effusion? So if it is extra, then you will carefully check that effusion, there will be no pulmonary marking. But when there is consolidation, there will be some pulmonary marking. Okay. There is no diaphragmatic outline, so it could be left low consolidation. Okay. And pleural effusion, if here, there will be, this is the basic things, difference. Um, what other things? And curvilinear upper border could be, is another things to differentiate, but mainly pulmonary marking is there or not. History of swelling behind his ear. It is another thing very important. Hmm. So when you say it is non-accident injury, you are saying it is mastocytitis, but which pictures you will go for this? So I think this could be like swelling is along the swelling there is like some injury mark over the ear also you can find, and it would be full, like it could be happen that um child having non-accident injury, someone injured this side, so it would be more spreading. Okay, some injury marks also you can find it. I think non-accident injury related another pictures was there, which is you can get it like same mastocytitis. Okay, swelling and there is some effusion. Okay, redness is there, so you have to differentiate. But the scenario you see irritability, swelling behind the ECR, they do not give us any risk factor for why Dr. Aisha want to join AKP class. Sudden shortness of breath, pictures of extra chest, what is the finding? Yes, looks like pneumothorax. Okay, so what is it is previous same lymphoma related and these questions I think who asked me this question previously. So this is the after accident develop tibial fracture. Okay, So after develop respiratory difficulties and heart failure features. So it goes in favor of scenario goes in itself goes in favor of fat in body. So yeah. Okay, and also there is a fracture sign, and but chest X-ray is not confirmatory. Okay, scenario should be there. Rhabdomyoma started on chemotherapy with 3 weeks neutropenia, fever for 7 days. Admitted, started IV antibiotic, but this condition deteriorated. Tachypnea, chest shows bilateral diffuse shadowing. What is the diagnosis? When chemotherapy related or cystic fibrosis related, okay, and patient having bilateral diffuse shadowing, then pneumocystis jirovecii, aspergillosis, tuberculosis could be, okay. So they could have bilateral diffuse shadowing, but we do not usually take tuberculosis until they say that some specific complaint would be there. Today is any, who is Dr. Aisha Taslim want to join? Okay, so it is Aspergillus pneumonia, okay? Because we do not get anything specific for tuberculosis, but more or less they looks like same, okay? We know that when we did our MBBS exam, that times one X-ray was there, they asked us what's the differential diagnosis for this. So in that times also we say these things, okay? But regional perspective, we take tuberculosis always from. Okay. 6 weeks old history of snappy nose in the previous 2 weeks with worsening of cough for 3 days after it becomes cyanosed, apneic, good feeding, but his feeding show slow with cough, normal with no respiratory distress. So any child after cough becomes cyanosed or after cough it becomes cyanosed and apneic, we will take pertussis. Some key messages or key point you have to remember. And the cough usually first stage there will be only cough, like laparoscopic infection. Then it become like whoop will come. 6 weeks baby delivered in 36 weeks. GA presented 36 gestational age present to the ER because of apnea twice in the previous 48 hours. He has one bottle feeding, changed the formula recently. Mother found him blue in the cot, covered with vomiting. She slapped him in the back and started to breathe and call ambulance. All examination is normal apart from faltering growth. After taking food, then it developed some aspiration related things as they are. But if it is occur first time aspiration, then there will be no faltering growth. Okay. There is apnea after giving feed. This always goes in favor of gastroesophageal reflux disease. 7 days born unit, discharge on the second day, poor feeding, lethargic, 2 episodes of apnea, CBC normal, CRP 12 temperature. Uh, so it, other than sepsis, what can we think? They do not give us any confusing options like inborn error of metabolism. Pakistan come fever cough for 2 weeks, fever and cough, you see, then they give the X-ray. So you will think over every related with the tuberculosis. So reasons they give, fever cup they say, okay, then X-ray. So how you are confused with this? But for tuberculosis, we will go for gastric aspirates. It is favorable for the pediatric age group. We have to check the X-ray here. Repeated chest infection. 18 months failure to thrive with repeated chest infection. It is also a question with debate. Okay, so everyone having different opinion for these things. I have some opinion. These questions maybe we discussed where I think infection chapter. Full question, I think it was a Indian girl. Okay, that was there, and repeated chest infection. If repeated chest infection, then you have to think that some immunocompromised condition could be there. But it is 18 months. Failure to thrive with repeated chest infection. Bowel problem is there, then we will think over the sweat test. But only repeated chest infection, okay? So we can think over that patient could be having rickets. Yeah, it could be. So we have to do the bone profile and skeletal survey. Dr. Amma Sadiq said ACD sweat test. Okay, so just careful that sweat test it is included in their day 5 test. Okay. So 18 months, day 5 screening test negative, but now come for repeated chest infection and you are thinking sweat. But cystic fibrosis having recurrent chest infection as well as could be some bowel related problem. Okay, so this is the things. Non-accidental injury could be possible. In that cases, you have to think over the CT brain as well. If non-accidental injury is there. But if they say that the child is an immigrant from outside country, that means cystic fibrosis is not screened out. Okay. So carefully look the X-ray. Yes. So sometimes a patient could be like come to us with upper respiratory infection and we do the X-ray and find the fracture. It could be possible. Okay. So if there is option posterior rib fracture, we will just take all the ribs. Okay. How it is look like. Cystic fibrosis, shock, vomiting, receive bolus, sodium, potassium, receive potassium replacement and ibuprofen after 3 days presented with the following. Yes, so it is a pseudo water. Okay. Hypokalemia is there. Vomiting. So metabolic alkalosis also could be. We have to give sodium, potassium. Okay. So it is same question. So patient having respiratory distress, receive amoxicillin, not improved. Come for later with prolonged cough, you will go for ultrasound. But what about the X-ray? What about the X-ray? So if you see the X-ray, then it is not the pleural effusion. It is the eventration. Yeah. So in that case, is also ultrasound of the diaphragm, not thoracic ultrasound. Now it is diaphragmatic ultrasound. 2 years old, cough on bronchodilators, not responding. Father is smoker, mother is asthmatic, sister has eczema, weight 0.4 centile, height on the 9th centile, chest extra hyperinflation, and peribronchial shadowing. What to do? Okay, if you say nasal brushing, then you are thinking differently. So if they say dextrocardia, 2 years old, cough on bronchodilator, not responding. Father is smoker, mother is asthmatic, sister has eczema. Weight point. So there is failure to thrive, and there is some wheezy child also. Mm, better to go for sweat test. Cystic fibrosis bottom. If you think primary ciliary dyskinesia, then nasal brushing. But primary ciliary dyskinesia mostly on the upper respiratory tract, recurrent upper respiratory tract infection, not the lower. Like recurrent otitis media, nasal polyp. If you can remember the pictures, you can easily say, okay. So here, some atopy as eczema also there, you see. But failure to thrive, then 2 years old Romanian, they said Romanian, okay. So it could be without any screening test, it could be possible. And hyperinflation, peribronchial shadowing, so also could be possible. Okay, so do you understand? Upper respiratory infection more related with primary ciliary dyskinesia. Can we call it, say, nasal brushing or something? Um, so if there is loculated pleural effusion, then chest drain with fibrinolytic. Okay, fibrinolytic is the treatment here. Now cough and breathing difficulties. This X-ray, you can say it is not pneumothorax or not consolidation, no features of foreign body only. We cannot see that any localized hyperinflation. Pulmonary edema, congenital cyst, wide mediastinum is not visible. New mediastinum, can we say? Some shadow around the mediastinum. It's not typical pictures of new mediastinum. Yes. So by exclusion method, you can go. So the pneumomediastinum. So gash, mediastinum, and pleura. Around the heart shadow, you get some more yard. It is more obvious, pneumomediastinum. Okay, so like this way. Known case of sickle cell, calf fever, chest pain. So now what is the features here? Lingual pneumonia. Hmm. Yes, diaphragm is intact. Uh, Same type of question here. Two answers. So you can take the right, middle lobe and lingual consideration. Febrile illness, calf, chest X-ray shows what is the step. Infant. So what is these things? Okay, so tell me this. Very important. These things we discussed in our radiology class. Okay. So you said ultrasound. It is infant, okay? Febrile illness and cough. And where you get consolidation on pleural effusion. Yeah, no investigation needed because this is thymus. Infant, and thymus shadow would be enlarged if they develop upper respiratory infection. So child having upper respiratory infection, okay, and this is infant. We know up to 4 years we can say it is thymus. So how they confused us? It could be happen, okay. So always take it in your mind. Oh, so long. Blue found him parents, Blue apparently lifeless, caught after they heard him choking, revised him mouth to mouth resuscitation, brought him to the hospital, 36 weeks gestation, weight 2.4 kg, no pain at all problem. Um, he feed well, but although he frequently regurgitated his feeds, parents report that he had been unwell with a cough for a few days before admission. Two siblings is 5 years and both in unwell, recent with chest infection. What is your most likely diagnosis? So where is the option? So many options actually. No option, or I should say long scenario. Okay. Unemployed, then considerable financial problem, pain, nasal discharge. So it is like a movie. Okay. So this is congenital cardiac abnormality, cystic fibrosis, gastroesophageal reflux, mild aspiration, pneumonitis, pertussis infection, viral bronchiolitis. Long scenario. So our mind want to go differently, but the scenario reveals, you see, wheeze is there. So be prepared with these types of scenario, long grip. Okay. Wheeze is there, fine crepitation is there, overinflation, financial problem, they say it, okay. But you see 10th percentile weight. So child is not failure to thrive. Frequent regurgitation could be at this age, 12 weeks possible, but no failure to thrive. Okay, so it is not gastroesophageal reflux disease. It is simply positing could be. And child having history of siblings sickness. Okay, child having apnea actually. So it is a viral bronchiolitis. But sudden unconsciousness is there, then you have to think like everyone, every scenario, they think over that it's non-accident injury was there or not. Must they will think. Okay, but they do not give us this option. That's very good. I was thinking of patient is non-accident injury, but there is no option. But milk aspiration related things are not here because overinflation, degree of overinflation, no localized opacities, and oh, so it's viral bronchiolitis. So, preterm neonate intubated 5 weeks, now 5 months, treated for recurrent pneumonia, high arch palate, X-ray shows patchy changes. What is the cause? So recurrent pneumonia, high arch palate, there should be recurrent aspiration. Okay, we have to check the X-ray. Pieri-Robbins syndrome could be, or Stickler syndrome, DiGeorge syndrome, they could have palatal problem. It is old question. I think after then most of the question is not repetition. Okay. So just we take this question, what is here? Looks like foreign body because like a specific area ways, localized ways. Okay. Originating inspiratory expiratory sign which start at the age of 3 months. Both inspiratory expiratory which goes in more favor of. If they say that it is from birth or patient having intubation, then we will go for subglottic stenosis. But so it is started from 3 months and now 6 months. So how can you go for bronchiolitis for this scenario? So vascular ring could be okay. Inspiratory expiratory sound. So when we call it laryngomalacia, having, they will say that some inspiratory expiratory sound or stridor, but it is vary with the respiration. Child is thriving well. These types of things they will say. Okay. And the next scenario, 2 years old boy, 2-day history of cough, inspiratory noisy breathing, a runny nose, fever, respiratory 60, there is a mild intense retraction. So what is now you think? Yeah, true. Laryngotracheobronchitis. So it is laryngobronchitis. Above 1 is 6 months. It is blue. Yes. Vascular ring foot pain. Cough, fever, then develop biphasic stridor. Unable to anything by mouth, respiratory rate 50, SP 93%, management action. After fever, cough, then develop stridor. They cannot take anything by mouth, respiratory rate is high, saturation 93%, best management action. Okay, where is the steroid? They do not give a steroid as an option. But is a acute laryngotracheal bronchitis. So other than steroid, we can go for budesonide. Nebulized budesonide, we can go. Okay. So you said all of you B, yeah, nebulized budesonide. But steroid is the first things. How is the extreme? And again, same question, Pakistan fever cough 1 month. Okay. Viral infection that develop hyperinflation, generalized wheezing and clubbing. Clubbing also after viral infection 6 weeks ago. Now wheezing, hyperinflation and clubbing. So do you find if you find clubbing, generalized wheeze could be hyperinflation, but bronchiolitis obliterans have not clubbing. Is it related with the clubbing? As I can remember, it is not related with the clubbing. Okay. So it should be bronchiectasis. So I correct here, okay? It is bronchiectasis. Why I said it is bronchiolitis, I cannot remember now. Clubbing, bronchiolitis obliterans after viral infection, it could be there, but you know, pertussis is important cause of bronchiectasis. Okay, bronchiolitis obliterans could be upper respiratory infection, it will continue, and they would have wheeze, hyperinflation is there, okay, but clubbing is not there. But bronchiectasis is mainly related with the post-crepitation. Okay, maybe with the wheezing, I was thinking for bronchiolitis obliterans, but clubbing is very specific for bronchiectasis. So you will take this information so that you can take your decision, okay? Multiple respiratory issue, crackles, clubbing. So it is bronchiectasis and infection, but condition that develops after a severe infection, exposure to toxic fumes with club and bronchiectasis, that is bronchiolitis obliterans. This is post-infection, which is a typical scenario for bronchiolitis obliterans. So bronchiectasis is a bronchi thickened, inflamed, and bronchiectasis itself not a disease, it's a finding. We can find this a chronic disease, including bronchiolitis. So it is bronchiectasis is a broad term. It includes also bronchiolitis obliterans. Okay, so I think bronchiectasis, if we say that it's not a lot wrong. Bronchiectasis is a broad term. It has structural damage already in the lungs, and it includes one of the causes bronchiolitis obliterans as well. Okay. So maybe it is written here that in this case scenario, just mention multiple respiratory disease and crackles and clubbing, which could be due to any pathology that is predisposed to bronchiectasis and infection. But condition develop after a severe infection or exposure to toxic fumes with clubbing and bronchiectasis, that is bronchiolitis obliterans. That is post-infectious, which is typical scenario for bronchiolitis obliterans. But after pertussis also bronchiectasis. One of the cause is bronchiectasis because severe infection with the pertussis. In that cases, it can lead to bronchiectasis. So again, we have to search that clubbing possible with the bronchiolitis obliterans or not. Okay. Please remind me. I will search it, and also you should search it. Okay, that clubbing is possible or not. Here, one of the only one problem is clubbing. If there is no clubbing is not written, then I will go for bronchiolitis obliterans because they just say it's one viral infection, then develop these things. Okay. So diaphragmatic hernia repair, then come milky aspirate. It means it is injury to the thoracic duct. Okay. After then you see after so many recall comes to the only these things. Audiogram. I was waiting for the audiogram. Okay. So you see here what happened. It is over 90 to 100. That means it is severe sensorineural hearing loss. There is no difference between the air conduction and body conduction. So it is a sensorineural hearing loss, but severe. Yeah. Other ear is normal. Left-sided. From consolidation of the left side, diaphragm is not visible, so left overlook consolidation. Okay, so try to do rest of the things. I think after then you will get many repetition. Okay, no doubt. So I just make one things here red. Uh, other things also there. So just look at this. Teenager known asthmatic patient come with cough for 1 month. Pneumonia, receive treatment, not improve, have yellowish fruity sputum. There is X-ray with no localized consolidation, exercise intolerance. What is the diagnostic investigation? Asthma patient 1 month cough, pneumonia treatment already get, but yellowish fruity sputum. Yellowish fruity sputum. Okay, I was also thinking that it could be. Where is the function? Where is the question nose? Yes, Mycoplasma pneumonia infection. Age is suggestive, and also wide extrapulmonary manifestation is there. Okay. Okay, so I hope you will go rest of the respiratory recall, okay, and solve yourself and also ask me in the next class if possible. Then we will discuss with the rest of the things as well. Okay, thank you. Any other things? Thank you. You can take leave. Good night. Assalamu alaikum.